Hi, this is Dr. Alice Lee. Welcome to iCubed. This is Emergency Medicine News' latest blog, so I'm very delighted that you've joined me. Every month I will be talking with a guest, probably one of my colleagues, about a case and just go through it as a clinician would. Most emergency physicians are clinicians after all. So let's welcome my guest this month. It's Dr. Jonathan Graff. Why don't you introduce yourself?
Hi, Alice. Jonathan Graff here. I've had the privilege of working with Alice for almost 6 years now. And so we've gotten to know each other quite well, which has been really nice. I was in California before that, where I also did my training. I was there for probably 14 years or so.
Wow, so you've been in practice for 20 years.
Yep, essentially 20 years.
Fantastic. Where did you do your residency?
So it was UCLA residency, and got to spend a lot of time at a lot of different facilities, including in Bakersfield at Kern Medical Center, which was a true pleasure.
Wonderful. Let's just start this case. So this is a lady I saw about 2 years ago. Now, not all hospitals are stroke centers. We have a stroke center. So we have a nice system set up that focuses our attention on the stroke or the potential stroke. So this lady was a stroke alert, as we call it. Stroke alerts go directly from the ambulance bay right to the CT scanner. The stroke nurse gets called at the same time as it's announced overhead, and the EP, or me, I go to the CT scanner or to the bedside right away. So this was a 96-year-old who is a reportedly independent living female, and she was at the hair salon when it was noted that she had sudden onset of left-sided facial droop, left-sided weakness, and she was brought in by ambulance. But there was nobody around. There was nobody to talk to, nobody to get consent or whatnot from. So we had a chance to look at the patient's chart, electronic medical record, and what the EMS brought in. So she has a history of AFib, hypertension, CHF, breast cancer, glaucoma, diverticulitis. We look at her meds. She's got potassium, temazepam, Lasix, vitamins, Xanax, aspirin, thyroid, mag, citrate, metoprolol, warfarin. We could have guessed that because she has a history of AFib, right?
Sure.
Yeah.
But at that age, sometimes the patient and or family and or cardiologist will elect not to put them on it, depending on what their risk is.
Right. The vital signs are this: 164 over 115. Her pulse is 92. Her respirations are 26, and her sats are 90% on room air. Looking at her general exam, she was in mild distress, awake. She was not talking. She had a gaze that was fixed to the right. Okay, she was otherwise looking like a 96-year-old. Obviously, the most important part of her exam is the neuro exam, right? So her left upper arm is flaccid. Her left lower extremity, it sort of withdraws with pain, but it's not working normally. She has spontaneous, purposeful movement of her arm, her right arm, and then her right leg, she was moving it spontaneously like normal, but she won't and doesn't follow commands. So what do you think right now?
Well, already being on warfarin, that's exclusionary criteria. It's something that I wouldn't get too excited about trying to complicate it. But one of the questions I didn't hear was the timing of this. She was in the hair salon. What time had elapsed by the time she showed up?
So reportedly the onset was witnessed at 1:20 in the afternoon. EMS showed up at 1:30 in the afternoon, and she arrived in the emergency department about 1:50. So we're talking within 30 minutes of the witnessed sudden flaccidity of the left side. What else would you want to know? She's on Coumadin.
Yeah, I would be very reticent to move forward, as we know that time is brain.
Yeah, that's right. That's what we keep
and it's within that
told.
First hour and a half, which is usually the most successful time to do it. And so we really would otherwise be very eager to get involved and consider TPA in a patient like this.
Right. Because it's a stroke alert, things get done very, very quickly. The labs are back. Of course, one of the first things you are thinking about is the INR, right? This is a lady who's on the Coumadin, And in the deepest recesses of my heart, I'm hoping the INR is 2 or so I can legitimately just say right away we can't give her TPA. But the INR came back 1.5, which is within the criteria, right?
Yeah.
So now we're within that, still within that first 60 minutes of the acute onset of the stroke. So the labs come back quickly, the CT gets done quickly, and the CT results are here. There's nothing acute on it. So we have overcome several barriers already. Yeah. Overcome some exclusion criteria on this 96-year-old lady who's a functional lady. She's at the hair salon. She lives by herself, reportedly. We have no family around, and she cannot answer your questions. She does not obey your commands. So I'm looking at this woman who would normally be out doing her hair or perhaps driving or whatnot. Now she suddenly has this devastating hemiparesis, and I can't communicate with her, right?
Sure. This is a case where, again, you noted there's no family, right?
Nobody around. There's no family. We can't reach. I think we try to call the daughter that's on the medical records, but we couldn't reach her.
Mm-hmm. Well, the obvious dilemma here is, and really, I wouldn't see it to be a dilemma, because if she has this profound weakness, I think her NIHSS score would be greater than 22, something I wouldn't TPA. And so I would be very reticent in this elderly individual to do that. The only way I would do it necessarily is if I were able to get in touch with family.
Right.
And be able to say, hey, it is worth it. She's not going to have quality of life. Let's give it the college try.
Right.
Mom would want it that way.
Right.
And if they could express that, because apparently the patient's not expressing it herself.
She can't.
So here I definitely step back and, as you mentioned, hoping the INR to be high, I would find a reason not to TPA her, which I think we have. And
that is what?
Well, I think the NIHSS. I think the severity of the stroke is so big that the risk of a catastrophe in this elderly 96-year-old is so high that I would see that as a reason not to TPA her. Again, I'm open for suggestions.
Right. Hence, this is why this was a difficult decision case. It's an interesting sort of intellectual, ethical, moral dilemma case where, as the physician, is where you feel the responsibility for this other person's future neurologic status or life, right? It's in your hands. You feel like that, at least at the moment you do. Let me back up just a little bit. At the time I saw this patient, I had already become a fan of endovascular intervention for TPA. I had some cases prior to this that really won me over. So when I saw this patient, one of the first things I ordered was a CT head and neck angiogram.
Was she allergic to IV dye?
Well, you picked it up pretty good. So then I had to cancel it because her medical records showed that she was allergic to iodine, and it was a significant allergic reaction. So I didn't want to cause, I guess, an anaphylactic response, even though I had become quite a fan of endovascular intervention, in someone who had a devastating hemiparetic stroke, right? So whenever I struggle with a TPA, whether or not to give TPA, I almost always get in touch with a neurologist. Okay, so in this case, I call our neurologist on call and discuss with him my dilemma, the struggle I was having, because I like to make collaborative decisions with my patients, especially with TPA administration.
Always smart.
Yeah. But in this woman, I couldn't, right? I had no family, and the patient couldn't talk to me.
Right.
And so I thought the wisest thing was to get in touch with the neurologist, whom you assume know the criteria much more stringently or much more clearly than we do. So I discussed the case with our neurologist on call at the time, who felt that the patient met criteria and that we should go ahead with the TPA. Well, I reluctantly agreed, and fortuitously, someone reached the daughter.
Nice. That's always good.
So within a few minutes,
That's great.
as you see, I talked to the neurologist. I'm getting ready to order the TPA. Someone reached the daughter a few minutes later. The daughter and I talk on the phone.
I'm dying to see the outcome. I'm dying to see the outcome.
Well, I think this is really more about the thinking process and the struggle we have when we have these difficult cases.
And I think the wonderful news here is that you got family involved, and it sounds like they knew mom to say, hey, she'd want to give it all a chance right now, or die trying.
Right. So I have heard it said, and this was what my own father expressed at one point in his life. I've heard people say that, well, I don't want to live like this, just do it. And so I could imagine this 96-year-old independent living woman might say that to me, might say, you know, I can't live the rest of my life with half my body paralyzed. Just give it a try, you know? But how do we impute that to somebody else, right? Yeah. You can't speak that to someone else. Your family may be able to speak for you. For instance, this daughter was able to.
That's the beauty of it.
Yeah, so in this case,
beautiful thing.
We have one neurologist who said, yes, she meets criteria, go in. Fortuitously reached the daughter who said, go ahead, give the TPA. So then, me being ever careful, I called our neurology department chairman about this case.
Nice.
This case may not be a struggle for someone else, but it was one for me. I might have overthought this. Nevertheless, I get the neurologist, the neurology chair, and the daughter all just said, who agreed to go ahead and give the TPA. So
what happened? Alice, what happened?
Well, before we get to what happened, I just want to ask you, would you have thought differently, or would you have acted differently or decided differently if this patient was, let's say, 35, 55, 75?
For sure. We extrapolate our own experiences
of course, yeah.
on other people, and we try to be as objective as you can. However, you go with, as you mentioned, your experience, all the cases and patients and family responses you've gotten through your training and through the years as this has gone on. And so, yeah.
Do you think you would have acted differently? Would you have been more eager to give the TPA, let's say, if the patient was younger and hemiparetic?
I almost would be more resistant to impose my my personal sentiments on a decision like that, which is really what this is.
Yeah.
And I would not want to impose my personal sentiments. And so the blessing was the daughter responded. Yeah. I think that's really the big thing, where you then got to know, hey, what would this patient want? It's their life.
Yeah, right.
How do they want to live it?
Right.
You know, are they waiting for a granddaughter's or great-granddaughter's wedding and would rather be alive and hemiparetic for that granddaughter's wedding?
Correct, right.
Or, no, they've seen them all. They don't anticipate anything coming up. I'm going to give it all I got. Right. Give me the gusto.
Right.
And I don't know that.
We don't know that. Right.
And so for me to give the gusto, like I might want to do, or my parents, or my experience might say, let's give the TPA. I am very reticent for me to jump in. And so I would find a reason, as I think there was, and would have held off. That's my thought process.
Yeah, sure. So these are, what you're saying and what I was thinking, these are very human factors. Now, what about the idea that if a patient comes in and meeting all the criteria like she did?
That's a different story. I think if they meet the criteria, and again, it's myself, if they meet the criteria, I am biased from my own experiences, and I would want to give her every opportunity.
Okay.
And so if we're meeting the criteria, we're trying to follow that criteria, I think in that situation, I would give the TPA to give her every fighting chance.
Right. So in this, let me just talk about...
To live a life that she had been living.
Right. In terms of my practice and administration of TPA, my practice has changed fairly dramatically. I think when TPA came out 20 years ago, being pushed by non-ER doctors, there was generally a sense from the ER community of reticence and really not wanting to give it. And I certainly was one of those. In keeping with everyone else in my group anyway, we were very, very hesitant to give the TPA. The 6% bleeding risk was just way too much. But that was 20 years ago, and we've had so much more data. Working within the system I'm in this hospital, that's now become a stroke center, my practice has really sort of evolved from a what I thought was justified reticence to following the hospital guidelines. And I don't know how I feel about that, but just in everyday practice from shift to shift, that's how I get through my very, very busy shift.
So we've changed,
mm-hmm.
and there's been more and more experience.
Right.
And in fact, not only do we change, not only is there more experience and more statistics and numbers,
mm-hmm.
but the population has changed worldwide with this, certainly in the Western world.
What do you mean?
So they also are aware of these things. They also are more educated. We now have a lot of access that's available, not just to the healthcare community, but to the population.
Mm-hmm.
I remember a case where someone didn't meet the criteria.
Yeah.
They were visiting from Germany.
Oh.
And they said, I want that clot busting medicine. And they were eager about that. They would give that clot busting medicine over back in Germany.
Interesting.
They don't understand everything.
Sure,
they
right.
just hear about it. But the population is
mm-hmm.
ready. I think they understand better mm-hmm. some of the consequences. And so I think there's been progression, mm-hmm. not only with the healthcare professionals,
mm-hmm.
but also with the population.
Yeah.
And they can make a better decision, and they're more informed, and or at least familiar.
More familiar, right?
With some of the pros and cons.
When I was researching for this episode, I looked at a article, and I pored over this article quite a bit, and so I just want to quickly go through that with you. Okay.
Yeah. I think I'm familiar with this.
The bottom line with this article was that most lawsuits were for
not giving it.
Yeah. So my fears, and most of my colleagues' fears, early on when the TPA was being touted as the miracle cure and pushed, our fear was always that we're going to cause harm and we're going to get sued, right? Or we're going to cause harm, and that's inherently what doctors are not supposed to do, right? It's the Hippocratic oaths and all that. So then when this article came out, or at least when I was told of this article, it really made me start thinking that in the system we work in, with the litigious society we work in, and it has become, perhaps it's wiser to function the way the system is working.
Well, I think the message is out there, and I think that if you have a good structure in your facility, and good support staff, that really helps make these decisions a lot easier. So when they go to the ICU on TPA, they have a team that's aware of that. They have someone who knows what the criteria, how to follow up on them. They know what their other options or resources are. They have all these abilities around them, and it helps. It helps to move forward with more confidence and more efficiency.
So, Jonathan, for me, what helps me feel comfortable with my decision is to always kind of look at guidelines and look at policy, because you assume that if there's a policy or guideline, that organization behind the policy or the guideline is going to come behind you if there's any question of your decision making, right?
Yeah.
Right. So this one article we just talked about, the one about TPA and the litigation and the closed cases, at the end of that article, the editor's comments, he makes some comments. And one of the comments was that the perceptions of medical legal consequences of TPA use in stroke may be overstated. You know, you and I are Generation VR doctors from 20 years ago. We were all very reticent, you know, and even prominent emergency medicine educators were also very much against giving the TPA. So
Right.
we were very much influenced by those educators.
Yeah, the training itself.
Right, and their training and the educators. But as it's been 20 years, and so there's more and more data that's being collected. And now even ACEP has their clinical policy come out just within the past few years. And the level A recommendation was that IV TPA should be offered to acute ischemic stroke patients who meet the National Institute of Neurological Disorders and Stroke inclusion or exclusion criteria and can be treated within 3 hours after symptom onset. So this is our own professional society's recommendation. It puts my mind and perhaps my heart at ease when I'm deciding a difficult case like the one in this screencast. My personal reticence notwithstanding, strictly speaking, she met the criteria, right? And she, having met the criteria for TPA, therefore we are following level A recommendations from ACEP.
So what have you pre-treated this patient? Here you have a significant stroke, certainly one that doing clot retrieval may have been of benefit. What have you considered, or do you feel bad that perhaps you could have pre-treated and gotten the patient there within 8 hours to get clot retrieval in this case?
I think that's a great thought. I didn't even think about it. At the time, I think that decision, it was a load off my back, sort of. I felt, oh, okay, so we've got everybody on the same page, and even though this is risky, everybody's on the same page, we're just gonna go for it and see what happens. Because, you know, once you've made a decision, you kind of went forward. Sometimes, I don't know if you do this, but once you've kind of pushed the ball down the hill and it's gone, and you just kind of go to the next patient.
Sure, you have another case just coming through the door.
Right. This more controversial recommendation recently, this is level B recommendation from ACEP, which is to consider using IV TPA for ischemic stroke patients who meet the European Cooperative Acute Stroke Study if they come in within 3 to 4.5 hours. What's interesting, I didn't know this until I read this, that the level B recommendations for the 3 to 4.5 hour strokes is based on another set of criteria. It's ECAS, ECASS, and not NINDS. So there's slight differences between the NINDS criteria and the ECAS criteria.
That's great, Alice.
So with every screencast, I would like to leave us with two main learning focuses. For this case, I think the first one would be ACEP's clinical policy. They recently just came out in 2012 with a clinical policy for TPA administration in those who present within 3 hours with a ischemic stroke. And we are to offer TPA in those patients that meet the NINDS criteria. Now, to me, offering a treatment does not mean that it's absolute. Clearly, with something so complicated as TPA administration, we have to use our judgment. We have to be very careful and thoughtful in our administration of this medication. Second learning focus in this episode, I would say, is collaborating. You want to collaborate with your patients and their families. You want to collaborate with the specialists. I've always tried to do that. I've always tried to collaborate with the families and patients, and the specialists will be needing to decide on these very difficult cases for the rest of our careers. So to me, the safest and wisest way to go in complicated decisions would be to collaborate. So the case concluded with no change, And the next day or two, she was discharged to hospice. Palliative care. There was no change.
Wow.
Yeah. But we wouldn't have known that.
No, and
so in the ER, as ER doctors, this is our burden or our cross to carry, which is we don't know the results of our decisions. So much of the time we don't know.
That's so true.
Right. So we have to, in real time, make the best decision we can, given our training, our humanity, and all that, right? And although her ultimate result was not what we had hoped for, I think that the process through which we went to make a decision for her, to give the best chance for her to recover, was, in retrospect, appropriate and the right thing to do.
That's a great case, Alice.
Thanks.
I appreciate you letting me be involved in the discussion.
I'm delighted that, Jonathan, you could join me on this episode. And thank you for listening to this screencast. And we'll see you next time. Bye.